Hello everyone. Today I'm going to ask you two very straightforward questions. Question number one is, what do you think makes a good doctor? A good doctor means who is very, very specific to her patient. When you cater the specific needs with specific procedure or specific medication or specific plan to your patient, that's how you are identified as separate from the crowd. You think about your patient, the procedure or the medication or the plan which is going to be most efficacious for that particular patient and give her the least number of complications. My second question is how you become more knowledgeable. You become more knowledgeable when you ask yourself questions. When every decision for every patient you take and you keep on asking yourself questions, why I am doing what I am doing. Or the another way is, if you are fortunate enough to be surrounded by people who keep on questioning every decision you take and ask questions for everything you do. I will say I am very fortunate to be surrounded with those kind of people who keep on asking me hundreds of questions for small little things I do, for small little decisions I take. And when they ask me questions, I think in my head. I'm forced to think, I'm forced to read to support my theories with evidence. And recently, when I was taking the class on Colpocleisis, I was bombarded with so many questions for which I had my theories, but many of them were not evidence based or evidence backed. So I started going through the literature in detail. And I came across a very beautiful review article on Colpocleisis, which actually backed up all whatever was in my head, that the procedure is decreasing not only in India, but beautiful procedure. There is the art of Colpocleisis is being lost from the entire world. So there is a definite need to rejuvenate it. And there are many, many more answers which are beautifully explained in this review paper. It will not be fair from my side if I keep that knowledge to myself and don't share with you all. So today I'm going to read the same article with all of you and discuss the salient points in it. So today I'm going to read this article with you, which is published in Obstetrical and Gynecological Survey. This journal, unlike others, is different because other journals keep on publishing review articles and mostly original research, case series, and case reports. However, this journal publishes only the review articles. This article was published in the year 2017 with the title Vaginal Obliterative Procedures for Pelvic Organ Prolapse, a systematic review. I will start with the history of colpocleisis. Initial surgical approaches for prolapse reduction actually consisted either of narrowing of vaginal caliber or reduction of vaginal hiatus. The reason was that entry of the peritoneal cavity was tried to avoid because at the time good antibiotics were not there and it was associated with mortality rate as high as 80 to 90% if you opened the peritoneum and it got infected. Romain Girardin was the guy who was credited with first presenting the concept of partial colpocleisis at one of the society meeting at Metz in 1823. In 1868, which was around 40 years after that, Ludwig Adolph reported performing similar procedures for 12 patients. Leon Lefort, as we know, is the first one who was credited with publishing the first written account of colpocleisis in 1877. Though the procedure was already published at the time, but probably because internet was not there with us that time, he was unaware that Nuke Bohr has already published this procedure earlier. What Lefort said was he did not consider this surgery as an obliterative procedure. He specifically stated that it is possible to have coitus even after the patient has undergone colpocleisis, which is partial colpocleisis as described by Lefort, which we are even performing in today's world. He said it was very easy to accomplish and had durable, successful results. Then in 20th century, when antibiotics became more freely available, vaginal hysterectomy was added into the armamentarium of treatment of vaginal prolapse. Even after the availability of antibiotics and vaginal hysterectomy for prolapse being in its boom, Herbert Adams performed the first total colpocleisis. He reported a series of 30 patients in 1951. In this total colpocleisis, vaginal epithelium was excised completely and the prolapse was reduced by placing sequential purse-string sutures. Plication of levator and transverse perineal muscles was also done at the time of closure. And the outcome was excellent in all these cases which were published, and he stated that the complications were minimal. Total or complete colpocleisis was usually done for wall prolapse patient, and soon enough, a very good procedure of sacrospinous ligament fixation was developed in 1958. Now, for vaginal prolapse with uterus, the procedure of choice was hysterectomy, and for wall prolapse, it became sacrospinous ligament fixation. Thus, colpocleisis became a reserved procedure only for frail, elderly women for several decades. And you will be surprised to know that if we just see United States, the number of Lefort's procedures was 17,000 plus in 1992, and it lowered to only 900 procedure within 5 years, that is 1997. Even the number of complete colpocleisis reduced dramatically. 3,000 plus procedures or 3,200 procedures in 1998 to just 32 procedures in 1995. If you are new to the subject, what we are discussing here today is vaginal obliterative procedures for case of prolapse. It can be of two types: complete colpocleisis or total colpocleisis, which we do for wall prolapse cases, and Lefort's colpocleisis or partial colpocleisis, which we do for uterovaginal prolapse with uterus intact. Though Lefort, when he initiated the procedure of colpocleisis, of partial colpocleisis, he said it was not an obliterative procedure. However, in today's classification system, this comes under an obliterative procedure. The most favored points about these colpocleisis procedures is that they do not require general anesthesia. It can be performed under local anesthesia, pudendal blocked, or regional blocked like spinal anesthesia. The procedure is short and patient is usually discharged within a day or so. Now the first question is, which patient should we select for performing a colpocleisis procedure? A procedure which has high success rate with low morbidity. So a colpocleisis is definitely a procedure for elderly and frail. However, It can be a procedure of choice, also for a woman who is well counseled, who does not desire vaginal functions or values a minimally invasive procedure with high success rate and minimal morbidity over maintaining the potential of vaginal intercourse. Thus, it is crucial to ask each and every one of your patients about her goals and expectations with regard to the surgery. Patients are more likely to be satisfied with the outcome of an intervention when their subjective goals are met rather than objective goals set by others. The flip side of this is that because following a Lefort type colpocleisis, cervix and uterus are no longer accessible for evaluation, many gynecologists screen for cervical and endometrial malignancies prior to Lefort's colpocleisis, and many are scared that what if patient develops it later. But if you look at the facts carefully, for a woman with history of normal cervical cytology, the risk of developing cervical cancer is low. The lifetime risk of women developing endometrial cancer also is only 2.6%, and the median age at diagnosis is around 64 years. And definitely, the risk of endometrial cancer in women who are more than 75 years is very, very low, that is less than 0.6%. So in elderly women, definitely there is nothing that should worry you. The second question is, even if you are doing a colpocleisis procedure, should you go ahead and do hysterectomy for that lady or not? Now, there are several reports of vaginal hysterectomy being done at the time of an obliterative procedure. However, these reports do not allow for a decision on whether the added risk of hysterectomy is worth the benefit of eliminating the risk of cancer of cervix or the uterine corpus, which we have already discussed. As the age advances, both the cancer become a reality in previously well-screened women. Added risk of vaginal hysterectomy definitely adds on to the risk of increased operative time, increased blood loss, infection, and risk of conversion to laparotomy, and also of bowel and bladder injuries. What about the associated urinary problems? I will discuss both the leak and the retention. So the existing data do not justify prophylactic placement of suburethral slings. On the other hand, pre-existing SUI can safely be treated with concomitant placement of midurethral slings, which has a very good cure rate. The data shows that either in stress urinary incontinence, if you are placing a midurethral sling, or even if the patient has a high post-void residue, even if it was more than 100 ml, there is no increased risk of post-operative urinary retention following a colpocleisis procedure. And the best news is that for the great majority of patients, which is more than 90% of them, voiding dysfunction as well as irritative bladder symptoms are likely to resolve or improve following colpocleisis. So if you are planning to do colpocleisis for your patient, what are the surgical outcome and the complication you should be thinking about prior to the surgery? So here again is the good news that any kind of colpocleisis, the literature says, even if it is partial or total colpocleisis, both have shown consistently high efficacy for advanced pelvic organ prolapse with anatomical success rate of more than 90%. And the results are long-term and overall patient satisfaction is very high. The authors also give evidence that besides being reliable in reducing prolapse, the mass which comes out, colpocleisis also is likely to improve voiding dysfunction and also irritative symptoms, which I told you earlier, like urgency and frequency, in approximately 50% of patients. And not only this, even if the patient is having bowel symptoms like obstructed defecation or even fecal incontinence, colpocleisis, you can tell her that may help her to control these symptoms also to a certain extent. Thus, colpocleisis is a safe procedure for surgical correction of advanced pelvic organ prolapse. The surgical risks are low, including in very elderly population. The intraoperative overall complication such as bleeding that requires blood transfusion and also the injury to internal organ are less than 2% in most of the studies. Now, one very specific question is, does rectal prolapse occur after colpocleisis? Actually, according to my experience also, the risk of or the appearance of rectal prolapse becomes evident sometimes after colpocleisis. And the theories behind them are two. And as I always thought, that most likely it is not because of the treatment, but once uterovaginal prolapse is there, there is some kind of rectal prolapse also. But usually rectal prolapse is hidden and not that evident every time you examine the patient and ask her to cough. This entity is known as occult rectal prolapse. So the chance of missing an occult rectal prolapse is higher in these women who actually are also having advanced uterovaginal prolapse. The second theory is that once the colpocleisis is performed, the rectum is no longer able to prolapse into the vagina, thus it prolapses out of the anus. That also might be a correct theory, but yes, there is a little bit increased incidence in some of the reports and also in my personal experience that rectal prolapse might appear or might become evident after colpocleisis surgery. So what can we do to prevent this? It's very important to take the detailed history, and when the patient says mass per vaginum, never forget to, just because you are seeing a prolapse of uterus or prolapse of vagina in front of you, don't presume that only one mass is prolapsing out. Always ask for rectal symptoms, and if there are two masses or rectal prolapse, patient has noticed earlier, because in clinical scenarios it is not easy to demonstrate a rectal prolapse until and unless it is totally out. The next question is, what about the recurrence? All of us know that recurrence in a case of vaginal prolapse following a hysterectomy and reconstructive surgery is quite high. It is around 40%. However, the evidence says that the recurrence rate after colpocleisis is very, very low. One thing in our mind, people always are scared of doing colpocleisis because they think that the patient satisfaction won't be good and they will have high regret rates after an obliterative surgery like this. But the evidence doesn't support this mindset. With regard to colpocleisis in particular, patient satisfaction has been uniformly reported to be high with relatively low rates of regret. Regret was seen only in 3 to 9% of patients. Most patients had significantly improved body image per the reported literature. So if you have understood all these points well, tell me whether colpocleisis should be considered a surgery of last resort, or it should be a patient's choice. In the light of existing outcome data, one can argue that colpocleisis should be the surgery of choice for women with advanced prolapse unless they want to maintain capacity for vaginal intercourse. Actually, colpocleisis offers the highest success rate at the lowest surgical risk compared with any of the reconstructive procedures. I do not disagree that vaginal patency may be an important factor for one woman to take decision, while durability of surgery and low risk of complication can be a deciding factor for another woman, regardless of age. Now you have to answer yourself this question: is it ethical to withhold a treatment option that has proven to be effective from a patient just because she's not old or frail enough? And these last lines of this article, according to me, are the most powerful lines, that it is paramount in our patient's interest that as surgeons, we must leave our ego outside the operating room. As Lester Ballard stated in 1996, that colpocleisis is a procedure which is rarely done today, mostly because surgeons think that it is a defeat for them if they are not able to reconstruct the vagina and are going to obliterate it. And I think this is a very, very valid point even today, that we must leave our ego outside. We must not think that we are obliterating because we cannot reconstruct. The treatment option should be patient specific, based on patient's needs and patient's wishes. Once again, in his concluding remarks, Professor Gunhilde again re-emphasized the fact that in the armamentarium of management or surgical management of advanced prolapse, colpocleisis is a durable procedure with relatively low complication risk and very high patient satisfaction. Now it's up to you to decide what's good for your patient and what your ethics says. I have done my job to bring this very lovely article to you all. Though this article, which I just presented to you, was published in the year 2017, there is no dearth of recent evidences and literature supporting colpocleisis in the recent past too. This is the 2022 article which was published in IUJ journal. The question it has asked is, colpocleisis as an obliterative surgery for prolapse, is it still a viable option in the 21st century? And the answer I will just read in the concluding remark by the authors. Contrary to expectations, this review of literature provides evidence that rather than being a historical oddity, colpocleisis is very much present in the 21st century pelvic floor surgery toolbox. And if you are not sure how to perform a colpocleisis procedure, the tips and techniques in a video article have been published in IUJ journal in the year 2020. You can go through it. And if you want to see the more detailed explanation to the surgical steps, tips and tricks, you can watch our videos. We have recently posted 2 videos explaining the detailed surgical steps of Leffort's colpocleisis in this very channel. Thank you so much.